So what I presented in the EHA 2022 meeting is a pre-planned subgroup analysis of the ZUMA-7 prospective clinical trial that basically compares in patients that in principle are candidates for autologous stem cell transplantation that have a primary refractory or early relapse diffuse large B-cell lymphoma, axi-cel versus the standard of care, which is salvage conventional chemotherapy and consolidation with autotransplant. So I presented the subgroup analysis looking at the elderly population of patients, so patients age 65 years of age or older than that. And they represent around 109 patients of the global population of patients included in ZUMA-7. So basically, the clinical findings in this population of patients resemble quite a lot the findings that we had in the ITT population. So more than 90% of these patients that were randomized to the axi-cel arm, they were able to end up being treated with axi, while only 34% of the patients that were randomized to the standard of care arm ended receiving autologous stem cell transplantation. And the major reason for that is that they did not achieve a complete remission or a partial remission with the standard of care. Event-free survival was the primary endpoint of the trial, and the event-free survival for the selected population of patients was significantly better with Axicabtagene than with the standard of care, in a similar way to what we have seen with the intention to treat population. The overall response rate was also significantly higher in the axi-cel treated group versus the standard of care treated group, in the same way that complete remission was also higher in this group of patients. The median follow-up, I haven't said that, is 24 months, which is not so bad for the type of patients that we are analyzing here, because most of the events are being seen in the first 2 years after receiving therapy. So there was also a pre-planned analysis regarding overall survival, and the overall survival curves for the axi-cel treated patients were also better than for the standard of care treated patients, taking into consideration that more than 50% of the patients in the standard of care treated group, when they failed or they progressed to autologous stem cell transplantation, they received some sort of cellular therapy, so maybe axi-cel in third line, or maybe another anti-CD19 autologous CAR T-cell construct. Another important thing that I presented were the patient-reported outcomes that constitute really a very important endpoint for all these prospective clinical trials. That's also important because the elderly population of patients, they usually tolerate treatments less well than the younger population of patients. And in the same way that we saw in the intention to treat population of patients, the patient-reported outcomes, so in terms of all the validated questionnaires of the EURTC, which are probably one of the most used ones, they benefit axi in front of the standard of care, both on day plus 100 and then on day plus 150. The safety profile, that of course it's also an important issue of concern in all patients, but also in the elderly population of patients, was quite similar to what we know from other patients being treated with axi-cel inside or outside prospective clinical trials. Maybe the incidence of grade 3 or plus CRS and the incidence of grade 3 or plus neurological events was a little bit higher than the intention to treat population, but the rates were really quite acceptable, and everybody thinks that axi is a safe procedure in this population of patients, and in fact there were not specific treatment-related deaths to axi-cel in this group of patients. So basically, the conclusion is that, of course, for this elderly population of patients, where we have a big unmet medical need, and that have really bad prognosis because they are primary refractory or they relapse early after first-line treatment strategy, treatment with axi-cel could be a perfectly valid treatment option.